class will be on one of the important global health problem. So that is hypertension. It's a silent killer because no signs or symptoms. If left uncontrolled, it can lead to a heart attack or stroke or CKD or aneurysm or peripheral vascular disease, etc. So it's the number one killer in the world is hypertension, and definitely, unfortunately, this is a very asymptomatic. So this is from the WHO organization. It's a silent, invisible killer, rarely causes symptoms. Increasing public awareness is the key. That's what we are doing it. Is access to early detection. So very easy to detect the hypertension. So you don't require any CT or MRI or a very high-tech investigation. Just your BP apparatus and your will to record the systolic and the diastolic very accurately. So you have to respect your correct cough sounds. The first sound is the systolic and the last is the diastolic, unless the diastolic is very low. So then you can take it as a muffling, or the fourth correct cough as the diastolic blood pressure in cases of hyperdynamic circulatory conditions like gross anemia or beriberi or pregnancy, aortic regurgitation, etc., where you can hear the heart sounds till the diastolic is say 20, 30, 40. Okay. So rise in blood pressure is a serious warning sign that significant lifestyle changes are urgently needed. So don't require the pharmacological management from the day one of the hypertension therapy. What you need is the non-pharmacological management, your dietary approach, your exercise, your yoga, your meditation, etc. And if the blood pressure is very high in the stage 2 or the stage 3, so definitely you require drug therapy. People need to know why rise in blood pressure is dangerous. So this is very important. So the medication is very important in the part of hypertension. If left untreated, because it is a silent disease, an asymptomatic disease, no one is willing to take the medications for the lifetime. If they don't take the medications for the lifetime, so what will happen? You are supposed to tell what are all the dangerous complications of the hypertension and how to take the steps to control it. So this is the very important problem, medical problem, not only in India, all over the world. So this blood pressure is the amount of the force on the walls of the arteries as the blood circulates around the body. Blood pressure is the measurement of the force applied to the artery walls. So that is the blood pressure. See, as I told you that this is the most important risk factor, number one cause of the death in the world, whether it is high income regions, Central Asia, Latin America, Middle East, Southeast Asia, South Asia, Sub-Saharan Africa. So you name any continent or the country, so the number one killer in that country is hypertension. So as a postgraduates of the general medicine, so this is our disease. You should know everything A to Z of the hypertension. So what is the etiology of the hypertension? What is the pathophysiology of the hypertension? What are all the drugs that are useful in the hypertension management? And left untreated, what are all the complications these people are going to get it? So definitely, if you learn hypertension in a better way, and definitely the public and the society will get a lot of the help from your pens. See, after the high blood pressure, see the smoking is also a big risk factor. So don't indulge in smoking. Diet low in the fruits. See the simple, low in the fruits. Unfortunately in India, so very low fruit intake is there. So I have to improve the fruit intake, at least 3 to 4 or 5 servings a day. High BMI, so we are all overweight or the obese. So you have to concentrate on the weight management if they are overweight and the obese. So our BMI, normal BMI is 23. High blood glucose. So India is a diabetic capital, very close to the China with the highest number of the diabetics in India. So see the high blood glucose. So whether it is a fasting high blood glucose or the postprandial or the random, you have to keep the blood sugars as close to the normal as possible. Otherwise, it's again going to be a big killer. And unfortunately, high blood sugar and high blood pressure are very close friends, deadly duo, because of the same environmental factors. See, physical inactivity itself is a big risk factor. Physical inactivity, we are all facing this problem. Physical inactivity because of the motorization, because of the industrialization, etc. So the physical activity is very, very important every day, at least 10,000 steps a day. It's very easy to say, but it's very, very difficult to perform it. So definitely physical inactivity itself is a big risk factor. High dietary salt. So unfortunately, we are consuming nearly 8 to 10 grams salt a day against a normal intake of the sugar. Salt should be 2.6 or 2.4 grams. Alcohol usage is a very, very high. Every year, the alcohol sales has increased all over the globe and also in India and Andhra Pradesh and Godavari districts. That's low in the nuts and the seeds. So the dry fruits intake is also very, very less. Following the COVID, we are seeing a lot of the people are consuming these dry fruits. That's good. So the nuts, we have to take it in a high amounts. So the diets low in the nuts and the seeds itself is a big risk factor. See, these are all the mortality factors all over the globe. Diets low in the vegetables. So always vegetable diet is much superior than the non-vegetarian diet. Diets low in the whole grains. Diets low in the fish and the seafood. Fish is very, very good. So fish contains omega-3 fatty acids, that is protects your atherosclerosis. So it reduces your LDL, reduces your triglycerides and improves your HDL, and obviously that gives a lot of the benefit to the endothelium. So obviously endothelial dysfunction will not be there even though the person is a hypertensive or a diabetic. So that is the reason fish every day is very, very important and good. That's what Bengal people are consuming. So in the Bengal people every day they take 3 times fish, breakfast, lunch and dinner. So the fish must be there in all communities in West Bengal. So these are the important silent killers. Unfortunately, we are facing all these problems in Andhra Pradesh. So we are people who have high blood pressure, lot of the smokers, diets low in the fruits, high BMI, overweight or the obese, blood glucose very high, and then the physical inactivity is there. Dietary salt intake is more, pickles, papads, etc. Alcohol usage very, very high. Low in the nuts and the seeds, high cholesterol, the street foods, dalda. These are all rich with the high cholesterols. Diets low in the vegetables. Diets low in the whole grains and the fish and the seafood. So we have to improve these things. See, the take home point from this slide is you have to improve all these things. Otherwise, these are all going to be one of the biggest killers in the near future. Effects on the global deaths and the daily loss of the working days or the working hours. See, high blood pressure is again important reason to cause the global deaths. Global burden of the blood pressure related the diseases. So again, East Asia, Southeast Asia, very, very high. How hypertension is defined? Hypertension is defined as a systolic blood pressure equal or above 130. So that is the Western population. For India, we consider as the 140 as the systolic hypertension. Okay. And the diastolic is the 90. But here he is saying that diastolic blood pressure equal to or above 80. So if you consider 130, 80 as an hypertensive, and I think 80 to 90% of the Indians are hypertensive. So all of you are hypertensive. And all of your blood pressure is somewhere between 132 by 84 or 136 by 86. Okay. So we consider hypertension means systolic 140, diastolic 90. Why hypertension is a major public health issue? Because cardiovascular disease accounts for approximately 17 million deaths a year, nearly 1/3 of the total deaths. So nearly 1/3 of the total deaths are because of the vascular deaths. And one of the biggest risk factor for the vascular diseases is obviously hypertension. Of these complications of the hypertension accounts for about 9.4 million deaths worldwide every year. Out of the 17 millions, nearly the 9.5 billions was because of the hypertension. It is responsible for at least 45% of the deaths due to the heart disease and 51% due to the stroke, that is the CVA. Hypertension is one of the leading behavioral and physiological risk factor to which 13% of the global deaths are attributed. See, it's a behavioral disease. Okay, so what behavior? More smoking, more alcohol, less physical activity, more overweight, more obesity. These all will lead to your hypertension. And hypertension is again a big killer. So all people, even the pre-hypertensives, when the systolic blood pressure is between 120 and 139, we consider them the pre-hypertension. In the same way, the pre-diastolic blood pressure between 81 to 90, 89, we consider them as the pre-hypertensives. So you have to concentrate on these people, pre-hypertension. Two things will happen to the pre-hypertensives. One thing, they will jump into the hypertension group, or they may reverse back to your normotension group. So this is our duty, to make all the pre-hypertensives in the society to become the normotensives. Otherwise, they will become the hypertensives in the near future. So it's almost like a behavioral disease. So you have to tell all the foods that will increase your blood pressure, what are all the foods that will reduce your blood pressure, and what is the amount of the activity, physical activity is important for this. So all these things you have to tell them. So don't think that a doctor, a physician means always drugs, prescription, 1, 2, 3, 4, 5, etc. So as a physician, you have to spend a lot of the time on the non-pharmacological management also, the lifestyle measures. That is very, very important, because the prevention is better than the cure. Hypertension is reported to be the 4th contributor to the premature deaths in the developed countries and the 7th in the developing countries. You need not remember these figures, the 7th or the 4th or the 11th. But one thing is very clear, that hypertension is a very, very big disease. If left untreated, is a very high mortality. 1 billion adults had hypertension in 2000, and this is predicted to increase to 1.56 billion by 2025. So within the 25 years, from 1 billion to 1.5 billion. So that is in a tsunamic proportion we are seeing the cases of the hypertension and diabetes. So if you see the blood pressure of your all the Sri Chaitanya and the Narayana intermediate group, so most of these people's the blood pressure will be somewhere between 130 by 84 or 85, and some people might be having the blood pressure of more than 140 by 90 also. So the childhood hypertension, because of the stress, because of the childhood obesity, because of the physical inactivity, because of the sleeplessness, because of the high intake of the saturated fats or dense calorie food. So these are all the contributing factors to elevate your blood pressure. So today the mean blood pressure remains very high in many African and some European countries. What you mean by the mean blood pressure? So the mean blood pressure is diastolic blood pressure. Diastolic blood pressure plus 1/3 of the pulse pressure. 1/3 of the pulse pressure. Suppose if your blood pressure is 120 by 80, so the mean blood pressure is 80 plus diastolic blood pressure plus 1/3 of the pulse pressure. So the pulse pressure here is the 40. So 1/3 of the 40. See the global burden of the hypertension projections. 26% of the world adult population had hypertension. So 1/4 of the adult population in the world are hypertensive. So very, very high projections. So mortality rate is also very high. Severe mortality rate is high. So what about the Indian scenario? Prevalence of the hypertension to be 25% in the urban India, and nearly the 10% in the rural people in India. And nowadays, even in the rural India, hypertension is also increasing because of the urbanization of the rural India. Okay. According to the WHO, the prevalence of the raised BP in the Indians is about 32.5%. Male and the female almost equal. Andhra Pradesh highest, 13.3%. So our people, the blood pressure is very high when compared to the people of the other states. See the prevalence of the hypertension in India. Hypertension is soon turning out to be one of the most lethal diseases in India. Already turned. We are seeing a lot of the cases in the ICUs, either in the cardiac ICU or the neuro ICU or in your medical ICU. So a lot of the people are hypertensive. And we are seeing a lot of hypertensive encephalopathies, hypertensive strokes, hemorrhagic strokes, ischemic strokes, acute myocardial infarctions, arrhythmias, acute left ventricular failure. So they are all the cases we are seeing day in and day out because of the uncontrolled blood pressure. So the people in India are hypertensive nearly 30%. 1.5 million people died due to the hypertension in Southeast Asia each year. Very high numbers. People in India with hypertension by 2025, nearly 214 millions and 21 crores. See the urban India and the rural India. Now the urban's 33%, rural India is also catching up, 25%, because of the urbanization of the rural India. What are all available in Rajahmundry are available in Ramchadovaram or Maredimilli. So that is urbanization of the rural India. The same figures here. See projected trends of the hypertension burden in India. See the Indian men and Indian women. So the projections are very, very high. See the first one is the 2000s and the next one is the 2025. See the hike. So it's a very, very high proportion in the number of the hypertensives rise is seen. So that is from the Lancet. See the physical activity is very important. So that will lead to hypertension. Obesity will lead to hypertension. Management is very important. Sometimes your steroid drugs may cause hypertension. Oral pills may cause hypertension. Your NSAID therapy, your all painkillers may raise the blood pressure. So these are very important. And of course, smoking in any form is always dangerous in all the individuals, more so in diabetics and hypertensives, because that aggravates atherosclerosis. And nutrition is very, very important part. So the good nutrition. So in nutrition, you have to concentrate on the carbohydrates. Complex carbohydrates are important rather than the simple carbohydrates. Avoid maida, avoid sugar, avoid ghee, avoid see saturated fats. So these are all very, very important. Okay. See the more grains, more brown rice, more quinoa, okay, more milk products, etc. is very important. So the rules of the halves. So these are very true in hypertensive individuals. What you mean by the rule of halves is half of the hypertensive patients remain undiagnosed. So nearly 50% of the people, they are living without knowing that they are having the hypertension. So very asymptomatic, 50%. Half of known, they do not receive the treatment. So having known that they are the hypertensives, still they are not on the treatment because it is an asymptomatic disease. Whatever the prescription you give it, as long as they are asymptomatic, they don't take the medication. So that is there. And those people, half of the people, those who are on treatment, they do not achieve the adequate control. Whatever the prescription you have given it today, so they will keep on continuing the drug for another 1 decade or the 2 decades or 3 decades. It's because in hypertension, you have to uptitrate the dosages. You have to put the combination drug therapy. You have to put the ARB, you have to put the calcium blocker, you have to put the chlorothalidone or hydrochlorothiazide, etc. And according to your creatinine levels also, you have to uptitrate the dosages. Maybe alpha blockers or central acting drugs like arcamins, etc. So this is the rule of thoughts is very, very true in our Indian population. Again, I am saying that half of the hypertensive patients, they remain undiagnosed. They don't know that because they're asymptomatic. Half of the known, they do not receive the treatment because it is asymptomatic disease. And half of the known and also on treatment, they do not achieve the adequate control. Adequate control means you are 120 by 80 or less than 130 by 80. So even though they are hypertensives, the blood pressure is always 150 by 80. Sorry, 150 by 100 or 160 by 100 or 200 by 100, etc. So this is the very important. So a lot to be done. Your role is very high in this hypertension because you have to check the blood pressure of each and every individual who comes to in your OPs or the IPs and say whether the person is a normotensive or pre-hypertensive or hypertensive. If the person is turning to be a pre-hypertensive, tell the non-pharmacological management. If the person is an hypertensive, always tell the non-pharmacological management and also start the pharmacological management. And follow-up is very, very important in hypertensive individuals. A close follow-up is very important. So at least once in a month or once in 2 months or once in 3 months. So it has to visit a physician like you to record the blood pressure, to know the different multi-organ failures or target organ damages, whether the fellow is having retinopathy or not, whether the fellow is LVH or not, whether the fellow is having the proteinuria or not, whether the fellow is having any heart failure or any asymptomatic ischemic heart disease or any CKD, etc. So you are the right persons to see whether the fellow is having any target organ damage or not. Then you treat accordingly. If the no target organ damage is there, when the fellow is only hypertensive, that is a simple hypertension. When the fellow with the hypertension are also target organ damage, it's a complicated hypertension. So you have to treat these complicated hypertensions with not only your non-pharmacological management and the pharmacological management, you have to start giving the statins, you have to start giving the antiplatelet agents, start giving the antioxidants. Suppose it turns to be also a diabetic, so again OHAs or the insulin, etc. So this is a very, very important. Classification, you all know that it's a primary or the secondary. Primary hypertension, no cause is not known. Nearly 90 to 95% are the primary hypertension. The secondary hypertension, lucky people, provided if you identify the secondary cause. Because if you treat the secondary cause, they need not, you need not prescribe the lifelong medication. So what is the duration of the medication in your primary hypertension, essential hypertension? 1 year, 2 year, lifetime. Lifetime. Suppose if the diagnosis is secondary hypertension, what is the duration of your antihypertensive therapy? So control the secondary cause. Suppose the pregnancy-induced hypertension, so till they get the delivery, they are the hypertensive. After that, normal. Suppose it's a pheochromocytoma causing hypertension. So removal of the adrenal medullary tumor. So it becomes the normotensive. Suppose the renal artery stenosis. So put one stent there. So then the renal artery stenosis is gone. So the person will have normotension. If the person is having a hyperthyroidism, which is a very common in the society, so treat the hyperthyroidism with your neomercazole, etc., or your beta blockers, or your radioactive iodine, or some people with a multinodular goiters, so maybe the surgical excision. So the person will be again normotensive. Suppose the person is hypothyroidism, they will have the diastolic hypertension. So again, you treat the hypothyroidism according to your TSH levels. So put 1.6 mcg per kg body weight is levothyroxine dosages. So give accordingly to correct the hypothyroidism, and obviously again the blood pressure will come down. He will become a normotensive. So you name any cause, the Cushing's syndrome disease, etc. So these are all sometimes drug-induced hypertension. So the patient has been taking the steroids for some reason, maybe SLE or maybe rheumatoid arthritis, maybe steroid sensitive or steroid responsive bronchial asthma. Okay, or any systemic diseases or connective tissue disorders or autoimmune diseases or vasculitis, who use a lot of the steroids day in and the day out. So that could be the reason for your hypertension. So reduce the doses of the steroids if possible, avoid or stop the steroids so that the person will become a normotensive. So the secondary hypertension, so this is the topic of a purely physician's topic. Essential hypertension, anyone can diagnose, anyone can write, anyone can say that lifetime treatment. But secondary hypertension, you are supposed to identify the secondary cause, especially young hypertensive individuals. Very high blood pressures in the young individuals. In the same way, very high blood pressure in the elderly individuals. All these years, the blood pressure is well under control. For the last 6 months or the 1 year, the blood pressure is accelerated hypertension. So what could be the reason for this accelerated hypertension? It could be a secondary cause. Maybe a renal artery stenosis or Takayuki arthritis, etc. So identify the secondary cause and then treat that secondary cause, and the person will be normotensive. What are the risk factors? A non-modifiable. So we can't stop the years. Gender, 99% we can't change the gender. Family history, so we can't change our parents. And ethnicity is also, we can't change our nationality. So whether you are settled in Australia or America, you are an Indian-born American or Indian-born Australian. Okay, so these four are very, very important non-modifiable risk factors for the hypertension. So hypertension runs in families. Hypertension is more in the males, and post-menopausal age group, again, that will be increased in the females also. And ethnicity, unfortunately, Indian genes are very, very, very worst genes as far as the health is concerned. So our genes are very worst. We are having more incidence of diabetes, more incidence of hypertension, more incidence of ischemic heart diseases, more incidence of malignancies, and of course, you can know the communicable diseases, very, very high. Number 1 for HIV, number 1 for TB, number 1 for malaria, number 1 for filaria, etc., etc. So for both the communicable diseases and non-communicable diseases, our genes are very, very, very notoriously affected for that. So age, gender, family history, and ethnicity is a non-modifiable risk factors for that. And these are the very important environmental factors. You concentrate on these and avoid these things. So alcohol consumption is always dangerous. So J-shaped curve. Initial days, they may reduce the blood pressure by relieving the stress and the strain. But once the fellow is addicted to the alcohol, and definitely the blood pressure will go up. Smoking in any form, mellitus, diabetes, so uncontrolled diabetes, so definitely that increases the risk factors. Elevated serum lipids. So dyslipidemia is again a big risk factor for the vascular diseases. Of course, dietary sodium, unfortunately, we are consuming, whether you like it or not, every day we are consuming nearly 10 grams of the salt. Obesity, not more than the 30, even the more than the 23 is dangerous. Sedentary lifestyle, we are all facing it. Socioeconomic status. Now the hypertension is a ubiquitous disease. So hypertension we are seeing in the rich and also in the poor and the middle class and lower middle class, upper middle class, etc. So most of the people in India, they are having the hypertension. So stress. So definitely from the 6th class or 7th class, IIT studies, NEET exams, etc. So a lot of the stress, especially for our medical students. So the clinical manifestations, frequently asymptomatic until severe and target organ diseases has occurred. So then don't allow your patient. We should not consider them as a patient, but we should not allow those persons with high blood pressure to reach this target organ damage. Okay. So what are all the symptoms you will have at that time? Fatigue, reduced activity tolerance, dizziness, headache, most probably occipital headache in hypertension, especially early mornings. Early morning occipital headache, more in favor of uncontrolled blood pressures. Palpitations, angina, dyspnea. So the dyspnea is nothing but angina equivalent or atypical chest pain. Okay. So they are all the some symptoms caused by the uncontrolled blood pressure when the blood pressure is very high. But most of the times, 90% of the people, those people will not have these symptoms. So that is asymptomatic hypertension. So we have to treat those asymptomatic hypertensives not to reach these symptomatology. What are the identifiable causes of the hypertension? Sleep apnea. So sleep apnea, obstructive sleep apnea is a big risk factor for the vascular diseases, snoring. Okay. So drug induced, I already told you. A CKD. So again, hypertension is both a cause and the effect of the chronic kidney disease. Uncontrolled hypertension will damage the kidneys, and damaged kidneys will produce the blood pressure or high blood pressure or hypertension. So you should know this. Primary aldosteronism, renovascular disease. Renovascular disease in two ways that will cause hypertension. One is vascular, the second one is parenchymal. So renoparenchymal disease like your CKD, your chronic pyelonephritis, polycystic kidney diseases, they all cause hypertension. And vascular renal artery stenosis, maybe because of the atherosclerotic renal artery stenosis or fibromuscular dysplasia, especially in the young females. Chronic steroid therapy and the Cushing's, pheochromocytoma. So you'll have the palpitations, tachycardia, perspiration, episodic events, the pheochromocytoma. The people presents with the blood pressure of maybe 280 by 200 or 300 by 200. So very, very high blood pressures. Coarctation of the aorta. So there will be imbalance of blood pressure, right upper limb and the left upper limb. Okay. So when the fellow is having the blood pressure of the right upper limb, 200 by 100, on the left upper limb, 100 by 80. So you should consider higher blood pressure as the hypertensive marking. So don't consider him as a normotensive, because on the other hand, it is a normotension. But once the fellow is hypertensive in any limbs, he is an hypertensive. But what is the difference? What is the cause for this? Maybe because of the coarctation of the aorta or subclavian artery occlusions or peripheral vascular diseases, etc. Thyroid, both the hypothyroidism and hyperthyroidism will cause hypertension. Don't think that hyperthyroidism will cause hypertension, hypothyroidism won't. That is not there in hypertension. In hyperthyroidism, you will have systolic hypertension. The blood pressure will be 180 by say 90 or 100 or 80. Whereas in hypothyroidism, you will have diastolic hypertension. The systole will be 130, but the diastole will be 98, 100. So very short pulse pressure, very small pulse pressure will be seen in hypothyroidism. So don't be happy in recording the systolic blood pressure in hypothyroidism. This is very important for the female physicians. Because from tomorrow, in the near future, you will be seeing a lot of the females. So most of the females will be having hypothyroidism. So in hypothyroidism, you have to see the diastolic blood pressure much accurately rather than the systolic blood pressure. Okay, systolic blood pressure will be 124. So don't be happy. If you check the diastolic blood pressure, that will be 100 or 108 or 110. That means diastolic hypertension will be there in those patients. Of course, parathyroid disease also will cause hypertension. So these are all important for physician point of view. So you only can diagnose these things. So essential hypertension, anyone can diagnose, anyone can treat. But these diseases, we are supposed to identify these reasons for your hypertension and then treat these causes so that the people will be normotensive. The pathogenesis of primary hypertension is still unclear, not known exact cause. Many factors associated with it. What are all those factors? Maybe genetic factors. So runs in hypertension, runs in the families. Always you ask any family history of hypertension, family history of the diabetes. Why? Because it runs in the families. So genetical factors. Sodium intake. So people who consumes a lot of the sodium rich diets. So definitely they are going to be the hypertensive. Renin-angiotensin system is a very, very important. Okay. Angiotensinogen, angiotensin 1, angiotensin 2, then A and B. So these are all very, very important. So you should know everything about this renin-angiotensinogen system. Sympathetic nervous system is a very common in our young hypertensive individuals. So sympathetic overactivity, hyperactivity of the sympathetic system will definitely cause hypertension. So here the beta blockers we use to reduce the sympathetic overactivity. Endothelial dysfunction is the very common. If left untreated, your hypertension, your diabetes, your high smoking, high alcohol, sedentary lifestyles, etc., they all cause endothelial dysfunction. And obviously, there will be a lot of plaque and then plaque rupture and thrombosis and acute myocardial infarction. Sometimes now, when you are sitting in the cardiac ICU, whenever you see a case of acute myocardial infarction, if you ask any risk factors, most of the times the patient will not have any risk factor. Diabetes of history, no. Diabetes, hypertension, no. Dyslipidemia, no. They are not overweight or obese. Smoking, no. Alcohol, no. But still, extensive anterior myocardial infarction or inflow lateral infarctions. Very commonly we see such people. So the reason is, again, a genetical or maybe some element of all these things will be there. And if you see the blood pressure, so that will be the pre-hypertensive range. If you see the blood sugars, they will be the pre-diabetic range. And if you see the lipids, they are not normal, maybe elevated above the normal, maybe limited. So if you add all these minimal increments in all these factors, and finally that is the cause for your acute myocardial infarction. So to avoid the acute myocardial infarction, especially in the young individuals, young means in medicine less than 40 years of age group. Okay, it's a very, very difficult to concentrate all these things. Insulin resistance is a very, very common. That is a root cause for your metabolic syndrome, Revance syndrome, Beer belly syndrome, insulin resistance syndrome. So that is your metabolic syndrome. So cluster of your diabetes, hypertension, dyslipidemia, and obesity. Now the fatty liver is also added to that, fifth parameter, and other factors. So the offsprings of the hypertensive parents are more prone to suffer from the essential hypertension compared with that without the hypertensive factor. So that is the reason you are asking the family history of the hypertension, because that runs in the families. Sodium intake, French fries. Okay, so your favorite dish in the interval times. The mechanisms leading to the hypertension are due to the increased blood volume and the content of the sodium in the smooth muscle cells, and hence following the subsequent calcium increase. Okay. C is obese, sedentary, okay, remote, and taking not one or two bunches, large. So this is the sympathetic nervous system. The activation of the sympathetic nervous system can augment the peripheral resistance, which increases systemic arterial pressure. So the blood pressure is nothing but cardiac output and peripheral arterial resistance. So the more the cardiac output, the more the blood pressure. In the same way, the more the peripheral arterial resistance, you will have the more blood pressure. So this sympathetic nervous system will increase your peripheral arterial resistance. See the other factors, the obesity, the waist circumference, it should be less than the 90 in the males and less than the 80 in the females. So 36 inches and 32 inches. Smoking, alcohol, obstructive sleep apnea, low calcium, magnesium and potassium. This is the good. So take more calcium, take more magnesium, take more fruits which contains the potassium. So they are the protective against your high salt intake foods. Systemic atherosclerosis develops with the increased intimal media thickness. So when you subject the carotid arteries in the CVA, we advise the CT brain or MRI brain and also Doppler, carotid Doppler. So the carotid Doppler, the radiologists, they say that carotid intima media thickness. So the more the carotid intima media thickness, the more the atherosclerotic vessels they are, leading to the ischemic alterations in the target organs, such as the heart, brain, kidney, and the peripheral artery. Even though they say that in the carotid arteries you have the carotid intima media thickness, that can apply to all the vessels in the body. So these are the people who are more prone to get the CKD. These are the people who are more prone to get the heart failure or the IHD. See the normal artery, first 1/3, and the middle one is the mild atherosclerosis, and the last one is the severe atherosclerosis. See the lumen, narrowing of the lumens of the vessel. So when the vessel is totally blocked, so you will have the necrosis of the distal areas where the supply is not there. In aorta and the large arteries, recurrent pulsatile stress produces uncoiling, disruption, calcification of the elastic fibers. At the same time, a relatively inelastic collagen is also increased. See the same vessels here, diagrammatic. See the normal human artery, endothelium, you can identify the endothelium there, and the smooth muscle. See what happens in the atherosclerosis. So there is an endothelial dysfunction, disruption, and macrophages, lipids, calcium, cellular debris, fibrous cap, smooth muscle cells. See all this will loaded there and finally leads to the narrowing of the lumen. So finally, that is the reason for your acute thrombotic or the embolic strokes. So the result of the aging as well as the hypertension, both processes cause loss of the normal elastic reservoir function of the arteries. High blood pressure is a sign that the heart and the blood vessels are being overworked. So hypertension means both the heart as well as the vessels, all the vessels are being overworked. Untreated, the disease can lead to the atherosclerosis and the congestive heart failure. So heart failure also. So as I told you, the complications of the hypertension, heart failure is also one of the complications of the hypertension. Again, 3 or 4 causes for the heart failures in Indian population. Now the heart failure is very, very common in the geriatric population. Now the people are living long, 80 years, 85 years, 90 years, very common in our society nowadays because of our advancements in the medical field. So the people are getting the young strokes, less than the 40 years of the age group, but still they can live up to the 70 and 80, 85 also. So once they live for the long period, and obviously they are more prone to get the heart failures. So one of the important reasons for the heart failures are the ischemic heart disease, diabetes, hypertension. So the complications of the hypertension are hypertensive heart disease, coronary artery disease, left ventricular hypertrophy that leads to the heart failure. Here the left ventricular hypertrophy itself is a big independent risk factor. It's very easily diagnosed by your ECG most of the times. And some people, they may require the 2D echo also to define the left ventricular hypertrophy. So this left ventricular hypertrophy is an independent risk factor to cause ischemic heart disease or the heart failure. So the drugs to reduce the left ventricular hypertrophy are your ACE inhibitors or ARBs. So once your ECG shows left ventricular hypertrophy, so you are supposed to prescribe ACE or ARBs and sometimes beta blockers also. Vasodilatory beta blockers like your metoprolol or bisoprolol. So cerebrovascular disease is a very common in hypertensive individuals, both ischemic strokes as well as the hemorrhagic strokes. Peripheral arterial disease. Nowadays we are seeing a lot of the peripheral arterial diseases because of the smokers, diabetes and hypertension. Nephrosclerosis and nephropathies, hypertensive nephropathy and the CKD is a very common in India. So two main reasons for the CKD are diabetes and hypertension. Retinal damage, that is a hypertensive retinopathy, hypertensive emergencies and hypertensive urgencies. So that is hypertensive crisis. It is having two things. One is urgency and the emergency. What you mean by hypertensive urgency? Here the blood pressure is more than 180 by 120, but without no target organ damage. So you can treat outpatient. So tell him your blood pressure is very high, but you are lucky that you are not having any target organ damage. So control the blood pressure very effectively with these medications. What you mean by hypertensive emergency? Here the blood pressure is very high, like in urgency, 180 by 120, more than 180 by 120, plus target organ damage. So plus proteinuria, plus LVH, plus heart failure, plus ischemic heart disease, plus peripheral arterial disease, plus retinopathy. Here you have to admit, either in your ICUs or in the wards. You have to admit it. You have to control the blood pressure very effectively in minutes to the hours. So don't take more than the 5 hours or the 6 hours or 10 hours to reach your normal blood pressure in emergencies. Whereas in urgencies, you can take hours to the days to reach your target. Am I clear? So hypertensive crisis is of two types, urgency and emergency. In both, the blood pressure will be more than 180 by 120. In urgency, no target organ failure, you can treat outpatient. In emergency, you will have a target organ failure and admit and treat accordingly. Dissection of the aorta is a very common in aortic aneurysms. So again, one of the important reasons to cause the aortic aneurysms or dissection of the aorta is hypertension. And recently, so the laboratory examinations, routine tests, okay, ECG is a must, as almost in all the hypertensive individuals, you should get an ECG. For what? To rule out your LVH, to rule out your IHD, asymptomatic IHD, to rule out your arrhythmias, atrial fibrillation, etc. Your rate, heart rate, to prescribe whether the beta blockers are there or not. Suppose the heart rate is 50. If the patient is on beta blocker, what to do? Reduce the beta blocker, stop the beta blocker. So rate is important, rhythm is important, and then the LVH is important, and ST elevations or ST depressions or T elevations, these are very important. QS complexes are very important. So these are all things you should be seen in an ECG in all hypertensive individuals. Urine analysis for especially urine proteins or CAS, especially the CKD population, or bacteria in urinary tract infection, provided the patient is also a diabetic. Okay, nitrate. So that is because of your E. coli urinary tract infections. Nitrate will be positive, present. So these are very important urine analysis. So don't think that urine analysis means only urine sugar and proteins. So you have to see the urine protein, urine sugar, urine microscopy, pus cells, and then the CAS, nitrite, blood in the urine. So these are very important. So blood glucose. So obviously every hypertensive is a potential candidate to get the blood pressure, blood sugars, diabetes, because these are a deadly DO. Hematocrit. So that is your hemoglobin, your PCV, CBP, complete blood picture, your hemoglobin, your PCV, packet cell volume, your MCV, MCH, MCHC, platelet count, polymorphs, lymphocytes, eosinophils. So they are very important in all the individuals. As a physician, so hematocrit means just not simply seeing the hemoglobin or the total count or the platelet count. You have to concentrate these other things also. These are very, very important. Suppose viral fevers, maybe there will be the lymphocytosis, maybe the bacterial infections. There will be the neutrophils will be 90%, 95%. The lymphocyte will be only 5% or 4%. The tropical eosinophilia. So the eosinophils will be 21%, 30%, 40%. Suppose the low platelet counts, maybe dengue. Sometimes we need not be always the dengue. So any viral infections, you may get the low platelet counts. Even in severe malaria, you may get the low platelet counts. So in all these things, as a physician, you have to concentrate on the hemoglobin, total count, platelet count, polymorphs, lymphocytes, eosinophils, and then the MCV, MCV and MCHC to rule out whether this anemia is because of microcytic hypochromic or macrocytic. Okay, so MCV 80 to 100. Less than the 80, it is the microcytic, very common in females because of iron deficiency anemia. If it is MCV is more than the 100, a macrocytic, more common in vitamin B12 deficiency. Serum potassium is very, very important in all the hypertensive individuals because the drugs you prescribe most of the times are the ARPs, your telmisartan, olmesartan. Sometimes the type 1 diabetes, maybe the ramipril or enalapril. So these drugs will cause hyperkalemia. Okay. On that hand, if the patient is also taking the potassium-sparing diuretics like your spironolactone, etc., again the chances of having the hyperkalemia is very high. And if you don't identify the hyperkalemia, so the people is going to die because of the cardiac arrhythmias. So hyperkalemia is a very, very big problem in all the hypertensive individuals. Those people who are on ARBs or the ACE inhibitor at least once in 3 months or once in 6 months or at least once in a year, you have to check the potassium levels. Suppose if the patient is in CKD, already the creatinine level is going up. In every visit, you should get the creatinine levels and also the potassium levels. If the patient is on the dialysis, so definitely have to get the urea, creatinine, and also the potassium levels. So the potassium is a very, very important investigation in all hypertensive, complicated hypertensive individuals. Creatinine, you know very well, and don't be happy with the creatinine alone, get the GFR. So age of the patient, gender of the patient, creatinine level in your smartphones, you will get the GFR. So according to the GFR, you act accordingly. So your doses modifications of the different OHAs or your hypertensive medications according to your GFR. So creatinine and the corresponding GFR is very important. Calcium. So most of the times, most of our people are having both the hypocalcium as well as the hypercalcium. So this you have to think twice while you are prescribing the different drugs. Lipid profile is very, very important, and without the lipid profile also you have to write the statins in all the hypertensive and complicated hypertensive individuals. So the lipid profile will tell you whether the LDL is the normal, triglyceride is the normal, etc. I think last class we discussed about the lipids in detail, and I told you something about the statins, I told you HTMI, I told you the fibrates, I told you the bempedoic acid, and also I told you the PCSK9 inhibitors. They are the monoclonal antibodies. So more extensive testing for the identifiable cause is not generally indicated unless the BP control is not being achieved. Very, very few, maybe 0.005%. Okay, most of the times, with a limited investigations, what I told you earlier in the first half of the presentation of this slide, they are sufficient for about 99.5% of our hypertensive population. But still you are in a doubt. Sometimes we may rate VMA levels, urine VMA levels, maybe to rule out your pheochromocytoma, etc. Sometimes we may require a CT abdomen, especially consider the adrenals, to rule out any adrenal tumor. Very, very rare. I have seen only 2 cases of the adrenal tumor for the last 30 years of my experience. Okay, or maybe 1 or 2 cases of other diseases. Very, very rare. So, but as a clinician, you should be well noted of all these investigations. They are very, very important. So the prevention of the hypertension. See there. So friends, simple walking is good. Okay, gardening, cycling, and then healthy diet. That 10 o'clock position is a healthy diet. The plate with a lot of nuts, green leafy vegetables, etc. So this is prevention. This slide itself tells you the prevention of the hypertension. So diet is good, friends are good, gardening is good, and cycling is good. Approaches to the primary prevention of the hypertension. Hypertension can be prevented by complementary application of the strategies that target the general population in individuals and groups at higher risk for high blood pressure. Prevention strategies applied early in the life provide the greatest long-term potential for reducing the overall burden of blood pressure related complications in the community. This is the population-based strategy. So this is a very, very important. Aimed at achieving a downward shift in the distribution of the blood pressure in the general population, and is an important component for any comprehensive plan to prevent the hypertension. A group discussions, a family discussions. These are very, very important. A small decrement in the systolic blood pressure is likely to result in a substantial reduction in the burden of the blood pressure related illness. That's the very, very important. What is the decrement in the systolic blood pressure? A small decrement, a small reduction in systolic blood pressure is likely to result in a substantial reduction in the burden of the blood pressure related illness. That is the beauty of this slide. Whether 2 millimeters of the reduction, whether the 4 millimeters of the reduction, or the 10 millimeters of the reduction, if you say that is very small, but that gives a lot of the benefit as far as the risk reduction is concerned. Risk of your retinopathy or risk of your heart failure, etc. is very important. See the benefits of lowering the blood pressure. What are all the benefits you get it? A stroke incidence reduced nearly 40%, myocardial infarction to the tune of about 25%, heart failure 50%. So the complication which gets the maximum benefit with your blood pressure reduction is the heart failure, followed by the stroke, followed by the myocardial infarction. Here, why the myocardial infarction is only 20 to 25%. For the myocardial infarction, not only the blood pressure, other factors also very equally important, like your diabetes, your dyslipidemia, your smoking, your overweight, and your genetics. Whereas for the brain, especially for the strokes and the heart failures, the proportion of the hypertension is directly related. So this is a Framingham heart study. So whenever you see any individual, so whether the risk score, what is the Framingham's risk score? Seen in analysis based on the Framingham heart study experience, concluded that a 2 millimeters reduction in the population average of the diastolic blood pressure for white US residents 35 to 64 years result in a 17% decrease in the prevalence of the hypertension. Just 2 millimeters reduction in the families or in the society. So there is about 17% reduction in the hypertension, a 14% reduction in the risk of the stroke and the TIS, and about 6% reduction in the risk of the coronary artery disease. So the 2 millimeters, you don't require any drug to reduce the 2 millimeters of reduction. A simple walking will reduce nearly 4 to 5 millimeters of the mercury. Your salt restriction will reduce about 3 to 4 millimeters. Your rich potassium diet may increase to 3 to 4, may reduce to 3 to 4. So 2 millimeters of the mercury reduction, you need not require any ARBs or the calcium channel blockers. With your dietary approach also, you can reduce nearly 10 to 20 millimeters of the mercury. See, reduction as small as 2 millimeters reduce the severe risk events by up to 10%. Public health approaches. See, what is the upper one? Salt. Public health approaches such as lowering the sodium content or caloric density in the food supply and providing attractive, safe, and convenient opportunities for exercise and ideal population-based approaches for the reduction in the average blood pressure in the community. Intensive targeted strategy. The more intensive targeted approaches aimed at achieving a greater reduction in the blood pressure in those who are most likely to develop the hypertension. Groups at high risk for hypertension include those with a grade blood pressure, grade 1 or 2 or 3 or 4, etc. A family history of the hypertension, overweight or obesity, smokers, sedentary lifestyle, excess intake of sodium, etc. What are all the risk factors you know of? So all these, you identify those risk factors, individuals in the society, and group them, and then go for the mass education. So this is the best slide of today's talk. Lifestyle modifications to manage the hypertension. Weight reduction. See recommendation, maintain the normal body weight. Your BMI 18.5 to not 24.9, it is 22.9. So for Indians, it is 23 is the upper normal of our BMI. So what is the reduction? 5 to 20 millimeters of the reduction for 10 kg weight loss. See the beauty of the weight reduction in all the overweight or the overweight individuals. Just in reducing the 10% of the body weight or 10 kgs of the body weight. Suppose the person is 100 kgs or 90 kgs. 10% means maybe 9 kgs or 10 kgs. What is the reduction of the blood pressure? 5 to 20 milligrams. So almost as equivalent of as of your 40 milligrams of your telmisartan or 5 milligrams of your amlodipine. Adopt DASH eating plan. What is DASH? Dietary approach to stop hypertension. So that is the right Mediterranean diet. Consume a diet rich in the fruits, vegetables, low-fat dairy products with a reduced content of the saturated and the total fat. What is the reduction? 8 to 14 milligrams of mercury. Then the dietary sodium restriction. What is the reduction? 2 to 8 mm. Physical activity reduction 4 to 9 millimeters of mercury. And a moderation of the alcohol consumption. Suppose the person is a very heavy alcoholic or addicted to the alcohol, we consider them as to advise them the moderation of the alcohol intake, maybe 90 ml a day. So here the 2 to 4 millimeters of mercury reduction. So while advising all these things, weight reduction, good dietary pattern, low sodium, good physical activity. So what will be the reduction of the blood pressure? Use amounts. So this is the beauty of our lifestyle measures in the management of the hypertension. So what is the DASH diet? Grains, number of the servings per day, 7 to 8, vegetables 4 to 5, fruits, low fat dairy products, meat, fish and poultry, nuts, seeds or any beans. Okay. Smoking, cigarettes. What is that? Pizza? Burger? Large burger? Ultra large? See, what is the waist circumference here? Is it 90 or more than 90? Maybe 110? See why I'm saying this. So you have to cultivate in your brain. So the ill effects of the abdominal adiposity, ill effects of the smoking, and ill effects of the diet rich with the calories. Okay. So this is the classification. So in India, we classified as the 3 stages. Whereas in the Western population, they stage only stage 1 and the stage 2. We have the normal, we have the pre-hypertension, stage 1, stage 2, and stage 3. So that is these figures you should remember. Okay, sit down. So the normal blood pressure is always less than 120 by 80. Pre-hypertension means up to 140 to 90. Stage 1 means more than 140 by 90. Stage 2 means more than 160 by more than 100. Stage 3 means more than 180, more than 110. Unfortunately, 80 to 90% of our hypertensive individuals, they are in the stage 2 and the 3. By the time they reach the hospital, by the time you see them, most of the time the blood pressure will be more than 160 systolic and the diastolic is more than the 100. Suppose if it is 160 by 100, almost they are in the stage 2. And yesterday I have seen one patient with 260 by 140. Okay, so he is in stage 3. Stage 3, that is accelerated hypertension, hypertensive urgency. So here what you mean by hypertensive crisis? What is the values for hypertensive crisis? Praneeth, systolic more than 180, diastolic more than not 110, add 10, 120. So 180 by 120, more than 180 by 120 is hypertensive crisis. Again divided into 2 groups. What are they? Urgency and emergency. What is urgency? What is emergency? Good. So this is how we have to divide the hypertension. So from tomorrow onwards, whenever you see an hypertension, whenever you record the blood pressure, so these things you should remember. Whether is a normal blood pressure, pre-hypertensive, stage 1 hypertension, stage 2 hypertension, stage 3 hypertension, or in hypertensive crisis. Okay, and is it hypertensive urgency or hypertensive emergency? What is malignant hypertension? So what you mean by malignant hypertension means very high blood pressure with papilledema. That is malignant hypertension. Good. So as a physician, you should remember all these things in your lifetime. So what are the benefits of the treating the hypertension? How good BP control helps? Each 10 mm decrease in the mean systolic blood pressure, 12% reduction in the risk of any complication, 15%, 11%, 13%, etc. You need not remember all these things. But even your 10 mm reduction of the blood pressure will give you a lot of the benefits. So for 10 mm reduction, do you require any drug? Even with your lifestyle measures also can reduce those things. UKPDS blood pressure study, tight versus the less tight control. What is UKPDS? Okay, UKPDS is a very important study now. In type 2 diabetes, you have the UKPDS study. In type 1 diabetes, you have DCCT study. Diabetes control and complication trials. DCCT for the type 1 diabetes, UKPDS for type 2 diabetes. Very important study. Very, very important study all over the globe. See, intensive group. What is the blood pressure here? 144/82. In less tight control, 154/87. So what is the risk reduction? If you keep the blood pressure under tight, that means less than 144/82. So what is any diabetes related endpoint reduction? 24%. 56% reduction in the heart failures. 44% reduction in the strokes. MI21, microvascular disease like retinopathy, 37%. So this is the importance of your tight control. So this is 144/82 is the tight control. Suppose if you keep it at 120/80, do you get much more benefits? Yes, 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 yes. So systolic blood pressure reductions as little as 2 mm, the risk of the CV events by up to the 10%. Classification. So these are all I told you, grade 1, grade 2, grade 3. What you mean with isolated systolic hypertension? ISH. Okay, in isolated systolic hypertension, the systolic blood pressure only will be high. So earlier we considered as 160 as the isolated systolic hypertension. Now it is 140. Suppose from tomorrow you have seen one patient with blood pressure of 140/80 or 150/80. What is your diagnosis? Isolated systolic hypertension. What is the drug of choice for isolated systolic hypertension? Good, calcium channel blockers. And then starts the letter I, diuretic, starts the letter I in indapamide. That is a metabolically friendly diuretic, indapamide. Okay, so that can be used in the isolated systolic hypertension, or as you saying that calcium channel blocker, they are also good for the isolated systolic hypertension. In whom it is more common, isolated systolic hypertension? Is it common in young or middle-aged or elderly? Good. Elderly. That is the reason you are using the diuretic. That is the reason you are using the calcium channel blockers. In young individuals, you use either beta blockers or RAS blockers. In diabetes mellitus, masked hypertension, sustained hypertension, normotension, white coat hypertension. You all know white coat hypertension. What is white coat hypertension? Hypertension in the chamber, normotension outside. That is a white coat hypertension. You need not treat them because they are hypertension only in the chamber. What is masked hypertension? Reverse of it. They are normotensive in the chambers, but they are hypertensive outside the chamber. So they are more dangerous. Masked hypertension. Masked hypertension. So how to detect the masked hypertension? Home blood pressure measurements. Okay. What is sustained hypertension? In the chamber, outside the chamber, the blood pressure will be very high. That is sustained hypertension. Normotension, always normotension. So this is the very important tensions. See, masked hypertension, office BP less than 130/80, but home BP more than 125/75. Day ambulatory blood pressure management more than 125/75, etc. Good. Management. So lifestyle changes. Smoking cessation, control of the blood glucose and the lipids, diet, alcohol. So all these things I told you. So this also I told you. Initial drugs of the choice. What are the initial drugs of the choice for the hypertension? ABCD. What is ABCD? A stands for A's and betas or ARBs. B stands for beta blocker. C, D. Anything else? Other than these four, any other drugs are there? Central acting drugs. Okay, like arcamin, which is very useful. In the same way, alpha methyl dopa in the pregnancy induced hypertension. See, general population, aged 60 years or older. Initial treatment, when the systolic blood pressure is more than 150 or diastolic more than 90. Goal of the treatment, systolic less than not 150, maybe less than 140. Diastolic not 90, less than the 80. General population less than the 60 years of the age group. Initial treatment, diastolic blood pressure more than 90, you have to treat it. What is the goal of the treatment? Less than 90, maybe less than 80. General population less than the 60 years of the age group. Initial treatment, systolic more than 140, start giving treatment. What is your goal? Less than 140, not less than 140, less than 120. Okay. Aged 18 years or older with CKD, with chronic kidney disease. Initiate the treatment, systolic more than 140, diastolic more than the 90. What is the goal? Again, less than 120, less than 80. In general, non-black population, including those with the diabetes, initial antihypertensive treatment should include any of these following drugs. In general black population, that means African population, including those with the diabetes, initial antihypertensive treatment should include a diuretic or the calcium channel blocker, whereas for us, this is an important slide. A compelling indications. So you are supposed to use these drugs when the fellow is having some diseases. For example, heart failure. So what are the compelling in the drugs to be used in heart failure? Your ACE or ARB or now ARNI, and then the beta blockers. Okay. And mineralocorticoid receptor antagonists like spironolactone or finerenone. Now the steroid sparing mineralocorticoid receptor antagonist. Last time I told you 10 mg and 20 mg. When the GFR is less than the 30, use the 10 mg. When the GFR is more than the 30, use 20 mg. Post-MI or the clinical coronary artery disease. In all the ICUs, the common drugs they prescribe is ACE, Ramipril, 1.25 or 2.5 or the 5, and then the metoprolol maybe 12.5 or 25, or bisoprolol, your Conquer, the 2.5 or the 5 mg. So ACE or ARB and the beta blockers are the compelling in post-myocardial infarction and ICUs. Coronary artery disease, same here. Here the ACE, beta blockers are the compelling indication to use in IHD. Diuretics, provided the patient is over obese. Calcium channel blockers, especially your diltiazem. Okay, non-pyridine group, diltiazem, that is also a calcium channel blocker. Diabetes, so ARBs are very, very important drugs. RAS blockers, calcium channel blockers are also useful, and a diuretic. And this combination, 3 drugs, is a very, very popular combined combination drug in the India right now. So your telmisartan plus amlodipine plus chlorothalidone, or your telma trio, or telma AH, or telmed AH, so etc. So the trio is ARB plus calcium blocker plus diuretic. In CKD, again the RAS blockers till the creatinine level is 3 or the 3.5, and after that you have to stop the ACE or ARBs. Then you start using calcium channel blockers, alpha blockers like prazosin, and then the central acting drugs like the arcamin, and loop diuretics like furosemide or the torsemide. So these you have to use it. Recurrent stroke prevention, again your ACE inhibitors. In pregnancy, so earlier we used the alpha methyl dopa. Now it is combined alpha and beta blocker. That is the labetalol. Is a drug of choice in pregnancy-induced hypertension. And you can also use the calcium channel blockers like the nifedipine. Methyl dopa is a central acting drug. And you can also use the beta blockers in pregnancy. So in pregnancy, 2 drugs are contraindicated, are diuretics and ACE or ARBs. ACE and ARBs and the diuretics are contraindicated in pregnancy. So these are the compelling indications. As a postgraduate, you are supposed to prescribe these drugs whenever the patient is having that problem. Okay. So the LVH is a very common in our diabetes or hypertension practice. So use ACE inhibitors or ARB and sometimes calcium antagonists, calcium channel blockers. Asymptomatic atherosclerosis. Again, the calcium antagonists or ACE inhibitors. Microalbuminuria. So obviously your ACE or ARBs. Microalbuminuria. Renal dysfunction. Again, ACE or ARBs. Still the creatinine level is 2.5 or the 3. Previous stroke. Usually calcium channel blockers. Here any agent effectively lowering the BP, but usually use calcium channel blockers in the stroke population. Previous myocardial infarction. So obviously your ACE, ARB are beta blockers. Angina, your beta blockers are diltiazem, that is a calcium channel blocker. In heart failure, yes, diuretics or the ACE or ARBs are beta blockers. Aortic aneurysm, beta blockers are the drugs of the choice because they reduce the heart rate so that they can reduce the leak of the aortic aneurysm. Atrial fibrillation, the prevention. So obviously we have to use ACE inhibitors or ARBs and the beta blockers or mineralocorticoid receptor antagonists like your finerenone or spironolactone. See the beautiful indications to use these drugs in the different conditions. So as a postgraduate, you should not do any harm to the patient in not prescribing these drugs in these particular conditions. We often see these, all these cases are there in our day in and day out office. In all the hypertensive population, we have such type of the subset of this population. Hypertension with LVH, hypertension with the microalbuminuria, hypertension with the past history of the stroke, hypertension with the IHD, angina pectoris, etc. ESRD are the proteinuria. So we don't use the ACE inhibitors or ARBs in ESRD. ESRD means end-stage renal disease. There, these are the drugs are contraindicated, but proteinuria you can use them. In ESRD, you have to use the calcium channel blockers or the loop diuretics, etc. Peripheral artery disease, don't use the beta blockers. So beta blockers are contraindicated in peripheral artery diseases. You can use ACE inhibitors or calcium channel blockers. ISH. So your isolated systolic hypertension. Vikram told that indapamide as a diuretic and calcium antagonist like your amlodipine or cilindipine. Diabetes, so ARBs. Renal in pregnancy, so methyl-dop is the earlier drug. Now we are using the labetalol, that are both beta and alpha blockers. In the blacks, that means the African population. So they use more of calcium channel blockers and the diuretics, not the ARBs. So resistant hypertension is nothing but high blood pressure in spite of 3 antihypertensive medications. Okay, so that is resistant hypertension. And all these 3 hypertensive drugs, you have to use it at the optimum dosages, not as 2.5 mg of the amlodipine or 20 mg of the telmisartan. Okay, so you have to use the optimum doses, at least 40 to 80 mg of your telmisartan or 5 to 10 milligrams of your amlodipine, etc. Then that is the resistant hypertension. So uncontrolled BP, despite more than the 3 optimally dosed drugs of the different classes, ideally including a diuretic, or controlled BP with more than 4 optimally dosed drugs of different classes, ideally including a diuretic. That is resistant hypertension. Not controlled with the 3 drugs, or controlled even at the control with the 4 drugs. It is a resistant hypertension. Subtypes: apparent resistant hypertension, true resistant hypertension, pseudo-resistant hypertension, and refractory resistant hypertension. Which of them, which one is more common in our society? So workup in the resistant hypertension, because this is our physician's topic. So we often see the resistant hypertension in our society. So you only can treat the resistant hypertension. Exclude the pseudo-resistant hypertension. Whether the patient is compliant or not, whether the patient is taking the drugs or not. Even though you are prescribing the 4 drugs or the 5 drugs, he may take only 1 tablet. Okay. Reverse the contributing factors. What are the contributing factors? Like physical inactivity or more salt, etc. Okay. Then the screen for the secondary hypertension, maybe renal arterial hypertension or pheochromocytoma or Cushing's, etc. Optimize the pharmacotherapy. Okay. Consider the derived based therapy. Non-adherence is very important. So these are all the secondary causes of the resistant hypertension. What are they? Primary aldosteronism, obstructive sleep apnea, renal parenchymal disease, renal artery stenosis, insulin resistance, prio, Cushing's, hyperparathyroidism, aortic coarctation, and tumors. When to suspect secondary hypertension? This is very, very important. Age, young age group, and very elderly. Less than the 30 years and more than 70 years. Abdominal bruit with a diastolic component, renal artery stenosis. Acute azotemia with your ACE inhibitors or ARBs, that is bilateral renal artery stenosis. Atherosclerotic disease elsewhere. Negative family history of the hypertension. No family history of the hypertension, but is present with very accelerated hypertension. Recurrent pulmonary edema. Renal failure without proteinuria. Severe and resistant hypertension. Smokers, bruise. So around 8 to 10% of the patients with hypertension have resistant hypertension. Apparent resistant hypertension needs a thorough workup. Non-adherence to therapy is a major issue, and consider the device-based therapy when optimization therapy has failed. 1.5 for your patient